Thank you for joining today's COP from Diagnosis to Dignity, Accelerating Access with Rapid Art and Outreach. We have created this space to engage in collaboration, thought partnering for innovation, and shared learning in the hopes of expanding access to rapid antiretroviral therapy. All of us are coming to the session with varying experiences, and we are counting on your expertise to make this an interactive session. Together, as we explore strategies new and old, we want to keep in mind the goal of today, to think about every individual beginning treatment quickly, safely, and with dignity. We're going to start with a disclaimer. The content in this community of practice is the sole responsibility of the authors and does not necessarily represent the official position of the Centers for Disease Control and Prevention. So I am going to pass this over to my colleague to introduce themselves, and then I'll introduce myself.
Thank you, Ms. Jai. Good morning, good afternoon, wherever you're zooming in from. I am Dr. Mariska Osborne-Wells. I have been with the Denver Prevention Training Center for a little over 5 years. And one of the things that I love about these trainings is just being in spaces to learn from others that are also passionate about STI HIV prevention. And that's what keeps me in the field.
Thank you. My name is Miss Jai Smith. I am a subject matter expert with the Denver PTC, and I've been working in HIV prevention and care for 15 years. So here are our learning objectives for today's community of practice. By the end of our time together, you'll be able to identify trauma-responsive approaches to outreach with Rapid Art services, examine common barriers to HIV testing and linkage to treatment, identify approaches to leverage Rapid Art services and outreach, and develop some strategies to integrating Rapid Art into diverse programmatic settings. We're going to accomplish this through some discussion and information on trauma-responsive engagement with communities, some self-reflection for folks who are watching this video, and then also looking at some current barriers impacting uptake of art in our communities. Finally, we'll chat a bit about mapping some adaptable plans to reduce those barriers while integrating some out-of-the-box approaches to engaging communities. And so with that, I'm going to pass off to Dr. M.
Thank you so much again. So for y'all that aren't familiar, trauma responsive systems and practices build on trauma-informed principles to create environments where people feel secure and respected. Organizations should be setting meaningful goals about the positive outcomes expected from being a trauma responsive organization within communities that have experienced a variety of trauma. In respect of our limited time together, I will be focusing on 2 principles of trauma responsive care. I will also share other principles that you can research later to see how they align with your organization. Next slide, please. So there are several tiers to be aware of when creating an environment for safety. That's going to be our first principle. We mentioned this to say that safety should not be an assumption. It often needs to be created and continuously monitored for improvements. Consider what practices build trust and reduce uncertainty in building community trust. This may look like being transparent and sharing your processes, how you make decisions, and listening to the expectations of community and acting to build on those. Most of all, follow through on what you promise. That means you're going to commit to it. We won't talk individually about the rest of these, but I want you to all think to yourselves about where fear, mistrust, or past harm show up in our organizational processes. What systems do you have in place to respond with empathy? Keep these in mind as we unpack Rapid Art and focus on incorporating trauma responsiveness in how you may roll this out in your community. We have opened the door for a trauma responsive perspective, and now we want to see what that looks like with Rapid Art and some of the navigation that we may be doing. Next slide, please. Okay, so first we mentioned peer support earlier as part of the principles. Many of you have used this method in your organization, so we're not going to belabor that. Next. So next one, we want to be flexible with our intake process. This means assess this process at fluid intervals to ensure it honors the varying needs of the people you serve. Avoid the rigidity of a checklist that could turn your clients away. Our third one approach that we're going to talk about is low barrier approaches to your care. I'll give you an example. In the setting of mobile clinics, outreach, pop-ups, etc., you want to have that ability to reduce delays in ART initiation or event testing. This can be done by minimizing the number of questions, being intentional with the information that you need. Our fourth approach in trauma responsiveness is the scripts. It's great to have a script, but we also want you to train staff to use language that is validating. Scripting does not mean you need to say the same thing and make it a robotic encounter. Make it personable. Put some personality into it. And as I like to say, zhuzh it up a little bit. Make it your own. Our fifth one that we want to talk about is your attention to the visual cues of safety. Much attention should be given to how visually welcoming and safe our spaces are for the varying populations. Walk around your whole organization once in a while and see it through the client's eyes. What stands out for you? And then lastly, centering accessibility as a core value, not an afterthought. There are intersectionalities in trauma, disability, and HIV stigma that requires some whole person approaches when designing outreach. One of the quotes from Dr. Nathaniel Curry, and I just want to read it to you because he's one of the advisory panel members that wrote the Trauma Informed Approaches Toolkit. And he said, it's not enough to provide healing care and then return them to the environments that traumatize them. I just want you to sit with that for a minute because this whole comment or his statement rang true for me and it sits deep because I thought of how we keep these initiatives moving forward. And with moving forward, how do we avoid harm? We should think first about what a trauma responsive approach looks like in real time. Think about your outreach methods, the language that is used. Are you being inviting or are you overwhelming? What about the messaging used for engagement, as well as the messengers of that message? Can they be trusted? Not a question we often want to ask ourselves, but when we think about this, we also go into retention. And retention is not just about getting appointments for the client. This is about building relationships and continuing the level of safety so they keep coming back. Next, Ms. Jai is going to take us through the barriers for intentional service delivery.
Thank you so much, Dr. M. So we start this off kind of with a question for you as colleagues. And so I'd like you to pause the video and think about this for a few moments, maybe write down a couple of thoughts. But what are some common barriers to trust, access, and retention in services among the communities that you serve? So pause the video and write down a couple thoughts. Thank you for that. So here are some of the common barriers that we often think of in addition to what you might have already written down. So one common barrier is transportation. The ability or inability to get to and from a service can be a barrier. Depending on when a clinic is open and if there are competing priorities during that time, that can be a barrier. If a service requires financial resources or insurance to access, or if there is a perception that it will be required, that can be a barrier. Fear of others finding out about HIV status or sexual orientation, or again, fear of assumption. So having assumptions about your HIV status or sexual orientation because of utilizing a service, that can be a barrier. And then there are also myriad of other barriers interpersonally, such as a lack of privacy in a home, concerns about disclosing to a partner, and fear of reaction from friends and family that can all be barriers to antiretroviral therapy and to care. But luckily, being able to identify and connect with people who are newly diagnosed or returning to care through outreach is one of the ways that we can address many of these barriers. So, rapid ART in an outreach setting is low barrier, which means that we are able to bring testing and linkage to care services to people through unique community engagements such as fairs, events, and community gathering places. This also looks like providing services out of 9 to 5 working hours, which is when folks may be working. So, this is an opportunity to meet folks after work. It builds trust by showing investment in getting to the people who need the service, and psychological safety by allowing clients to engage outside of a set brick and mortar location. It offers autonomy by creating avenues for clients to engage with services on their terms and in their own environments, including having many options for where and when to get health services, such as through testing or during testing outreach. It takes a peer-led and community-tailored approach by working with the community we are trying to serve and bringing services to the places where communities live, work, play, and worship. And it helps us to reach people who are living with a disability or are neurodiverse by not solely relying on getting clients to one location, which can be difficult for clients to navigate. So I'm going to share one example and what this can look like through outreach testing. So integrating rapid ART services into outreach testing can provide clients with multiple options for testing and rapid linkage to confirmatory testing and medication. It also provides more options for community members who are HIV positive to re-engage in care if they have fallen out of care. It ensures that all clients, regardless of their result of their test, will be offered next steps for care and either linked to confirmatory testing and treatment or linked to PrEP and other prevention methods to remain HIV negative. It means we can provide linkage to care to more sensory-friendly locations while ensuring privacy and confidentiality, especially in communities with easily identifiable HIV care clinics. So I think some of our rural communities, for example, where there aren't a lot of services, but everyone knows where the HIV care clinic is, that might be an easily identifiable HIV care clinic. We can also design outreach testing environments to be sensory friendly if traditional healthcare environments are overwhelming for our patients or our clients. So, sensory friendly environments are designed to support clients who have experienced trauma by recognizing that sensory sensitivities can be triggered by trauma. This means that steps can be taken to dim bright lights, reduce loud or sudden sounds or movements, offering testing at locations that are quieter or during quieter times, allowing flexible seating, reducing clutter in the testing environment, and alleviating smells as much as possible. This also gives us opportunities to request and analyze client feedback, identify new locations for testing, and deepen relationships with collaborating organizations. But beyond talking about how it can be effective and how things like outreach testing linking with antiretroviral therapy and rapid ART can be effective, we also want to leave you with some starting points for how you can make rapid ART work in your community. So one strategy is to pilot rapid ART pop-ups in trusted community spaces with organizations and communities you are already supporting. This can include a linkage to care specialist who is providing education about getting started on medication or scheduling appointments while talking to clients, and helping relink folks who have fallen out of care, or getting them connected to Ryan White services. Another strategy is partnering with artists, peers, and advocates who are trusted in the community to educate about rapid ART, getting connected to care and how to get testing. Utilizing community champions in this way can help to reach new audiences and provide validity to accessing services in the eyes of that audience. Another strategy is integrating rapid ART services with your outreach teams, even without a linkage to care specialist always conducting the outreach. So developing policies and procedures for outreach staff to collect contact information and provide warm handoffs to linkage staff as clients are identified who have fallen out of care or are newly diagnosed. Using feedback can help you to better identify where rapid ART services and outreach may be most effective. Through client surveying and reviewing the treatment cascade, we can start to illustrate where clients fall out of care and the experiences of clients attempting to link or relink to care. Through community needs assessment with trusted partners, we can identify new opportunities for outreach and engagement where we can provide rapid ART services. And in speaking about qualitative experiences, it is important for us to look beyond just the numerical metrics for how effective our services are. Providing rapid art in the field requires a lot of effort, and we may only identify a handful of people to receive that linkage support. So it is important to evaluate how rapid art in outreach is beneficial for those we are serving through the program. Collecting information on relinking to care, the client's trust in services, community perception of service provision, and adherence and maintenance for those who engage in rapid art can show how essential this approach is to the folks that you are serving. So now I'm going to pass it back over to Dr. M, who's going to talk about more ways we can meet people where they are.
Absolutely. And I think, when we think about how to meet people and where they are, we got to identify who are these people that we're talking to. So before we get outreach and mobile units in the most accessible, we have to think about the population. Let's look at what's accessible in the locations for that population that you're serving. And one of the ways we want to do this is looking at the geospatial data to identify the high need areas as well as the service deserts. And for those of you that are not familiar with geospatial data, it just shows where the gaps are. If I'm looking at a map and I don't see a gas station, then I'm probably not going to stop there. And that's just what we mean, just looking at where the gaps are. So while the health fairs and the community events are a great place for setting up a booth or a partnership with providers, consider the populations that are attending the events to be able to get more bang for your buck. Are they the intended audience or are they just a captive audience? So remember, this is about showing up where people are, and this may often be outside of the norm of prevention. While looking at this list that we're sharing with you of places, keep it in your pocket for potential partnerships. And one of the ones I really want to highlight that I'm excited about is the tattoo studios. I don't think that that's come up too much for folks, but think about it. There's needles that are being used. We don't know if that shop has good hygiene practices. We may be able to get some awareness. And once we have awareness, they start having conversations with the people that are coming in their shop. And that will lead us into how do we lay the groundwork for these partnerships and potentials. So next slide, please. So we just mentioned potential areas to expand on reaching individuals that can benefit from the services offered. And when we say services, we're not just talking testing and counseling. We're talking about that awareness raising. We're talking about PrEP and PEP. So it could just be conversations. Let's take a quick look at a method that can help give the biggest bang for the effort. This process takes place by doing a landscape scan. What are the existing clinics? What are the mobile units? Where are the mobile units going? The emergency departments that are in the area. Think about all of these things. Because essentially, where are people currently going and are we present? Clarify where service providers are landing in the care continuum and use the information to expand on the areas to fill the gaps identified. Firstly, identify the key players in the outreach and the rapid art ecosystem. These organizations are the anchor institutions where folks go for many services that encompass testing, diagnostics, and various medications. Art should be included if it has not been already. So how do we develop those partnerships? This is our next step. That warm handoff process between the testing site and the provider are crucial in maintaining engagement because if I don't know who I'm sending my people to, how can I vouch for them? How can I get them excited to work with someone else? So if a provider is not even available, consider how to keep the client ready for services without creating a large gap in testing to care and treatment. We want to establish points of contact that are verified every few months to assist in caring for the client's needs. And folks, we're not telling you to, you know, beat down their doors, but how do you build relationships that are sustaining? We want to keep them coming back to us. We want to say, you know what, we trust your organization. I'm sending this client to you. How ready are you for that? Simple as that. Next, we want to bring these into, we want to bring these into the space with the purpose of thinking beyond clinical pathways to care and treatment. Using the people in the neighborhoods that are serving the whole person, not just their sexuality. And that's what we mean by the trusted outreach points where communities gather. And sexuality may not even be the lead on the conversation. The popular opinion leaders, they're going to be able to tell us where we can meet the folks. And I will tell y'all, it's simple, something simple as a block party. You have a handout, say, hey, while you're here, we can offer testing. Let's go have a conversation, walk off and just talk to someone and build that awareness. Simple as that. Lastly, identify the trusted community influencer. Now that we mentioned that popular opinion leader, who's going to get their heads to turn? Who's going to get their ear to turn on for you? Because folks will shut down when they don't know who you are. But using that ability as a leader to share the message in that person, they're going to share the message in their authentic voice. That I mentioned earlier, try not to be scripted. Just give them the information, allow them to make it their own. Because overall, this person is the one that's going to get deep in the local culture and can be trained up with trauma responsive techniques to normalize HIV testing and ART in their own language. So, what will that look like for you? I know journey mapping may be a new word for some folks, but it boils down to a visual representation of client experience with a product, service, or brand from their perspective. It is by definition visualizing the steps, the emotions, and the barriers people experience when engaging with a system or service. We have been leading up to this in our thinking of who we are focusing on and how to identify the pain points in the services we are providing. An example of this is when you think about how the person navigates HIV care, how they're accessing it, we're also able to identify the barriers that happen, not just with the intake processes, but what experiences are they having with stigma? So we're able to get a visual picture of that entire experience for them. Next is the community-based participatory research. For those of us that have been in school, we know all about CBPR, and it is not great for everyone. But we embrace the firsthand knowledge, and sorry, most of not all, and I see I get caught up in school, but most, if not all of you in this space are familiar. In short, community members have equal say in what questions we are asking, the methods used to collect the information, as well as how it's disseminated for additional use. So when collecting information, we are expanding on the lived client experience of the community and extracting stories that honor their lives. This should not be exploited for information or check a box and sit on a shelf. Kind of like the doctor's oath. First, do no harm. I term it as first, don't re-traumatize. So let's not go in there and collect information to sit on a shelf. Lastly, the client experience. We embrace the firsthand knowledge and insights that clients and the community members bring when they are directly impacted by various systems. We want to hear these participants' perspectives that are often beyond our professional expertise and at the same time avoid exploiting them. The World Health Organization emphasizes that meaningful engagement of people with their personal perspective, their experience, requires respectful, dignified, and equitable inclusion, valuing their expertise to improve health outcomes. So let's put all of this into action and work through our scenario with Ms. Jai.
Awesome. Thank you so much, Dr. M. So now we're going to go through a scenario to help us think about how we could integrate rapid art into an outreach program. So I'm going to read through the scenario, and then I'd like you to pause the video and think about these three prompt questions that I will share after the scenario. So an HIV prevention organization is attempting to bring rapid art to the community through pop-up mobile unit testing events in public libraries across their service area. The organization already has a relationship with the libraries and has been providing testing, but has not been providing rapid art linkage to care support. The libraries cover a metro area, and testing is frequently attended by unhoused adults who attend to receive a gift card incentive. The outreach team had a couple of participants test reactive with a rapid point of care HIV test, but have struggled with effectively linking those participants to confirmatory testing and care, and most are lost to follow up after 30 days. So now I would like you to pause the video, and I'd like you to write a few sentences to yourself with for these three prompts. So what may be some barriers that need to be considered in planning for this rapid art to be part of the outreach that's already being engaged in these libraries? What are some strategies that the organization may be able to implement to effectively integrate rapid art into this existing outreach? And when the organization begins offering rapid art as part of outreach testing, how can the program evaluate effectiveness and satisfaction with the program? Go ahead and pause the video and write your thoughts. Thank you for taking the time to think through those questions. So we're going to start with the first question. In planning for rapid art to be part of this outreach, what may be some of the barriers that need to be considered? Here are some of the ways that we may plan for rapid art to be part of this outreach, and some of the anticipated barriers that we already might expect. So transportation to confirmatory testing or treatment may be a barrier, a lack of health insurance, housing instability, since we are working with folks who are predominantly unhoused, lack of phone and contact information, competing health priorities, stigma around HIV, a lack of privacy, and concerns around carrying medication. So thinking about the second question, what are some strategies that the organization may be able to implement to effectively integrate rapid art into existing outreach? Here are some additional ways that you may already have thought of around effectively integrating. They could train testing staff in linkage to care. They could conduct a blood draw after they receive a rapid test to draw a confirmatory test. They could collaborate to allow field staff to schedule with HIV care clinic for same day or same week appointments to start treatment. They could have a field nurse on call or on site to initiate the starting 7 to 10 day supply of medication in the moment, including for HIV care, syphilis treatment, and other co-occurring infections. They could also work with pharmaceutical companies to get sample packs of once daily medication. And then finally, for when the organization begins offering rapid art as part of outreach testing, how can the program evaluate effectiveness and satisfaction? Here are some ways that you may have already thought of, or maybe in addition to what you were thinking of. They could provide satisfaction surveying. They could create a focus group with participants or with staff or with both. They could review their linkage to care data and success with confirmatory testing, starting medication, and becoming undetectable if they have access to that information. So now we are going to move into our think tanks. The think tanks are designed to take a deeper dive into what we have talked about today, while also figuring out how you can apply what you have learned to the work you currently do and would like to be doing. The think tanks are split up into pies, one group for planning, one for implementation and integration, one for evaluation, and one for sustainability. The way this will work is I will move through the prompts for each of these. Depending on where you are at and what makes the most sense for your program or for your organization, you may find yourself in a planning stage. You may be past planning and ready to implement or integrate rapid art into your outreach services. You may need support with evaluation, or you may need support with figuring out how to sustain these programs ongoingly. So I encourage you to pause the video with each of these think tank prompts and write some responses to yourself that help you to start to flush out what this looks like. And at any point, if you would like additional support from us around how this could look for your organization, please reach out to the Denver Prevention Training Center. So these are the prompts for the planning group, or for if you are in the process of planning. So what are some outreach efforts that your organization or program are already conducting? Pick one aspect of outreach. This could be a mobile unit or site-specific testing. And what barriers might clients be experiencing that make it difficult to engage in rapid art in that environment or in that location? And then what are some ways rapid art in this outreach aspect could be structured to alleviate or overcome these barriers? If you already know where you would like to start doing rapid art as part of your outreach, then you might be in implementation and integration. So think about what has already taken place to integrate rapid art into your outreach efforts. What are your current standards of work or workflows that are in place? What policies and procedures will need to be drafted or implemented to roll out rapid art within outreach efforts? And then which staff will need to be trained and what supervision support will be necessary with the rollout of these policies and procedures for them to be effective. We should be thinking about evaluation regardless of where we are at in the process. And so when we are thinking about evaluation and evaluating the effectiveness of our services, what evaluation strategies have already been effective to assess linkage to care or other programs within your organization in the past? What will you need to measure? What metrics do you need to know if the program is effectively integrating rapid art into your outreach efforts? And then finally, how could you intentionally evaluate community and client experiences as part of the overall evaluation of rapid art in outreach efforts? Getting back to the qualitative experience in addition to the measurable outcomes. Finally, we want to be able to sustain our programs. So these prompts are to help you figure out ways to sustain your rapid art outreach program or rapid art integrated into outreach programs. So what has your organization done to ensure that programs are sustainable over time? How could outreach-based rapid art enhance your organization's current efforts to sustain it internally? What are some strategic outreach collaborations that will help sustain rapid art in your outreach efforts? I want to thank you for your time and for joining us today on this video. Please feel free to connect with us on social media through our website, through LinkedIn, or through our Facebook page. Here are our sources for today's training. And then finally, funding for this community of practice was made possible by PS 240020 from the Centers for Disease Control and Prevention. Thank you so much for joining us today.
Thank you.